So PCOS, an issue with women of reproductive age. And now we're going into perimenopause. And perimenopause is the transition phase into menopause. That's how you think about it. There are no great definitions. There are no great ways to characterize it. Basically, it's just that period in between reproductive regular cycles and menopause. And as to what happens, if you take care of patients like this, you know all bets are off. Anything can happen. It can take 4 to 8 years, average, and it can take as long as 15 years. I remember I did my first talk on this, and I'm learned that new factoid that it can take up to 15 years. And so I have my first perimenopausal patient in front of me after I prepared that deck, and she's like, how long is this gonna last? And I'm like, do you know it can last up to 15 years? Wrong thing to say. And the reason this looks like a roller coaster here, when you look at estrogen levels, is because it is a roller coaster. It is a hormonal roller coaster, and it's a bucking bronco, and I just try to help my patients hold on as long as they can, and they may fall off every once in a while and have a really bad day or a really bad week, and I'm there to support them and help them get back on. That's really what it is. Now, there are things that we can do to make perimenopause easier to experience without question. That's the pillars of health. And we can't minimize that. And then there's a piece of it that's purely hormonally related. And so we're going to talk about all of this. So it's these fluctuating and dramatically increased estrogen levels and decreased progesterone levels. So the first hormonal change that happens in perimenopause is a decrease in progesterone. That decrease in progesterone leads to a relative excess in estrogen. At the same time, you have fluctuation of estrogen levels. So with the diminishing progesterone, you can have more estrogen, which means that estrogen-progesterone balance is off even more. So it's not just what you think in terms of estrogen. It's really about elevated levels of estrogen. Most people think perimenopause has to do with decreasing levels of estrogen, but that's not the case. It's decreasing levels of progesterone with wildly fluctuating levels of estrogen, but a net increase of estrogen. So when we're talking about a pillar of health approach, the liver is so important because that's how we eliminate estrogen. And the gut is so important because that's how we eliminate estrogen. Remember that beta-glucuronidase in the stool, and constipation, and the disordered microbiome. And then urine is so important, and kidney function. So many of these perimenopausal symptoms are secondary to these higher estrogen levels. And so patients come to me, why are my breasts getting swollen again? I thought I was done with that. Why are my periods getting heavier? I thought I was done with that. Why are they getting more painful? I thought I was done with that. And this is why. And there's tons of data on this. So, if you're lucky enough to order a Dutch cycle map on this patient, you can show them exactly what's going on with their hormone levels. So you can show them where they're out of bounds, right? Where they're out of bounds. in your estrogen and inbounds with progesterone, which means you have a relative excess of estrogen, right? So now they see this on the paper, and they will be more engaged about what you can do to change that back to normal. Again, a close-up of the estrogen outside of the black lines and progesterone inside the black lines, therefore estrogen dominance. And you know from just thinking of all the ways you can do this with permutations and combinations, if you kept your estrogen the same, if you had your progesterone below, it would also be estrogen dominance. And if you had the estrogen in the norm and progesterone way, way down, it would also be estrogen dominance. So there's many ways to end up at this estrogen dominant state. So why do progesterone levels fall? And it happens in normal length cycles. So you then have ovulatory cycles that can start to get a little shorter. Now remember, what happens is, and I'm trying to find a politically correct way to say this, but the eggs that don't ovulate when women are younger become less efficient. That's a good word. They become less efficient in their production of hormone. So it's fits and starts just because the eggs aren't as efficient. And sometimes they're so inefficient that they can't even produce an egg. They don't even ovulate. So you have anovulatory cycles. So how do we know that we have an anovulatory cycle? Well, if we look and we see estrogen, this is not following that estrogen peak. And what's nice about this report and these reports is these black lines tell you, really, they're like the guardrails of a bowling alley and a bowling lane. They tell you where things should be. So we know that just from looking at the colors being outside of the line, we know that this is not a normal estrogen ovulatory cycle. Forgetting about whether we understood that estrogen should be low and it peaks in the LH surge, like you don't even have to remember any of that. You just look at this visually and you know that this is not a normal estrogen cycle. And then we look here and we see the progesterone is way low. It's also not normal. So this is an anovulatory cycle. You remember from my initial couple of slides, I said the time that progesterone goes up is in the second half of the cycle after ovulation, after that egg is made. So when we see progesterone that's low continuously, that's how we say the egg wasn't ovulating, or the ovary didn't produce the egg. And we have sophisticated numbers. If you're a reproductive endocrinologist or GYN, you can measure a progesterone level, a serum progesterone on day 21. And if it meets the criteria or not, we know whether there was an ovulation or not. So you look here, and it's pretty clear there was no ovulation. And at the same time, do we have estrogen dominance? Absolutely. So this is a classic anovulatory estrogen dominant perimenopausal woman who's going to be complaining of breast tenderness, bloating, mood swings. And as I said, we can vary because it's not like there's a switch, although there are some lucky women who regularly ovulate, then all of a sudden the switch gets flipped and they just don't have a period anymore. And if it wasn't for the fact that they weren't menstruating, they wouldn't even notice that there was anything different going on hormonally. Those people do exist. But I don't see that many of them. But I will tell you, when I was doing regular GYN, as opposed to now, which is functional medicine and functional women's health. So now everyone that has problems come to me. I still do well woman care, but before I was doing a lot more well woman care. And then when I was doing well woman care, there really were people who just didn't even know or wouldn't know that they were in menopause if it weren't for the fact that they stopped having monthly cycles. Now I see all of the different permutations and combinations of hormone imbalance, and it's the cycle map that helps me figure out what's going on and serves as a very important educational tool to explain to patients what's going on with them, because they all want to know what's going on. Then we try to figure out the why, and then we talk about the different ways that we can make things better. And tomorrow, you're going to hear cases that Monique Klass and I have. Monique Klass also lectures for IFM, and she'll be on the podium with me tomorrow. She's a nurse practitioner in my office. She's a director of coaching development for Functional Medicine Coaching Academy. We're going to tell you how we talk to our patients about these issues, and we'll do that through cases. So, this is here, and I always say, this is great for you to read and understand, and you don't have to think about it again. So really, all this tells you is that there's an early and late perimenopause, and that it's variable. Remember, I told you it can be up to 15 years, but we're going to keep that between ourselves. And that there's this variable cycle length, etc. FSH goes up. Remember, FSH is the hormone that causes the follicle to make estrogen. So when there's a call for estrogen, the pituitary secretes FSH. Now, during early perimenopause, estrogen and progesterone are changing in opposite directions. That's estrogen dominance, right? Estrogen going up, progesterone going down. Later in perimenopause, as we're approaching menopause, as we're approaching the sort of the stage of life of the ovary where things become very inefficient, then the ovary is not able to make really much estrogen or progesterone at all, and that's menopause. And the way we transition through that is we go from that fluctuating estrogen, lower progesterone, to low estrogen and low progesterone. And these changes can increase the risk for endometrial and breast cancer. So you need to just look at patients individually when we're trying to think about breast health and breast cancer risk. And this is where mammography can be very important, because no patient of mine wants to get breast cancer, and no patient of mine wants to take more mammograms or have more mammograms than they need to. And there's a lot of literature that too many mammograms can cause problems. So what do you do with this? And thankfully, I don't have to give a whole 45-minute talk on what I do for breast imaging and mammography, but what I will tell you is that in most doctors' offices, the left hand doesn't talk to the right hand. So when mammogram reports come in and they say dense breasts, what usually happens is at the radiology center, patients automatically given an ultrasound. And if that ultrasound is normal, it gets filed in the report as normal mammogram. And most clinicians don't see that. And so when you have a patient that's having these perimenopausal breast symptoms because of this estrogen-progesterone imbalance, then you need to look at the mammogram. I would say you should always know which of your patients have dense breasts or not. But dense breasts clearly are a risk factor for breast cancer. So in a patient that has dense breasts on mammogram and symptomatic painful breasts, and I always tell my patients, painful breasts are the bioassay that there's too much estrogen for your breast. It's not good, it's not supposed to happen. It's different than a breast lump, because painful breasts on both sides are really not about having breast cancer in the moment. But from a functional perspective, from a pillar of health perspective, you don't want to have painful breasts each month. So we have to work on looking at hormone production, look at increasing hormone elimination, and what helps us? The cycle map. The cycle map, because that tells us what's going on. And then if you see on mammogram, so you have estrogen dominance on your cycle map, you've got symptoms, and you have a dense breast on mammogram, then we're going to dig a little deeper, and then I want to look and see what the estrogen metabolites are, because I want to know how my patient is metabolizing or digesting her estrogen, right? And so then I got to think about the biochemistry and the cytochrome P450 system, right? And the 1A1 and the 1B1 and the 3A45. And know, are we hydroxylating in our phase 1? And we're going to have all these slides on this. But is she hydroxylating where she's supposed to on the second carbon, which can be cancer protective? Or is it on the 4 or the 16 carbon? Which can promote cancer. They can be cancer promoters. And what if she doesn't methylate well? So let's say she's COMT or MTHFR, and she now isn't methylating her estrogens well. Well, guess what? She's now producing more of the unhealthy estrogen. She's not methylating it to get rid of all of this increase of unhealthy estrogen, and that's a double whammy. So these are all the things we think about, and it starts with the cycle map showing the abnormal estrogen-progesterone ratio, and then the breakdown of estrogen metabolites, so we know whether we're metabolizing or digesting in a healthy or an unhealthy way. Now, vasomotor symptoms can be the driver for why people come in. Hot flashes. They may or may not be correlated to estrogen. They're very common, and again, this is another statistic that I learned I never mentioned, that these hot flashes can last up to 10 years. But that's important because I do have people that come in, I have new patients who have been in menopause 7, 8, 9, or 10 years that are flashing, and they think there's something wrong with them, and those are the patients where I'm very quick to tell them, oh, don't worry about it. It's normal up to 10 years, right? But you don't tell somebody that, obviously, at the beginning. And night sweats or hot flashes that occur at night, obviously. Now, this is an important piece of information here, and that is that the old approach to women with hot flashes was stick it out as long as you can and if you can. But now we know that hot flashes, in addition to being uncomfortable and miserable to experience, are actually deleterious to health. So it's incumbent upon you, as their treating physician, to try to reduce hot flashes. And there are many ways. It doesn't mean you have to give hormone replacement, although that's certainly a good way to do it if that's what you and your patient want to do. There are botanicals and stress reduction. Stress reduction, meditation, through the literature, is as good as hormones in reducing menopause symptoms. And now they have new medications. Just Bethany was talking about me trying to be up on the literature. So just last week at NAMS, or actually it was this week, NAMS, North American Menopause Society, there's a new class of drug that's just developed to reduce hot flashes that has absolutely nothing to do with hormones and works immunologically in the brain. So pay attention to that if you're really interested. You can dig deep into the abstracts of North American Menopause Society, and you'll see a presentation on that. So the point is, these vasomotor symptoms here, it talks about whether they start later in the day, they're not so good. It actually doesn't matter when they start. They're not good for the heart. You want to stop your patients from flashing, whether it be hormones, botanicals, stress reduction, healing the gut, working on all the foundational pillars that may be out of whack. That's what you do for the health of your patients. So, African American women, Native Americans, highest vasomotor symptoms, elevated BMI, higher when perimenopausal, fewer and milder when menopausal. Cigarette smoking, anxiety, and depression. High BMI and African American have the most severe. So, sleep and mood changes. Women with metabolic syndrome, poor sleep efficiency. I think you heard about this from Dr. Gersh so many different ways. I agree with every single thing she said. Sleep is critical. Circadian rhythm is critical. And there's this continuum between PCOS and PMS in terms of the problems that happen from poor circadian rhythm. And that's associated with vasomotor symptoms, and of course, mood is impacted by life stressors. So, vaginal and sexual symptoms can start to come out now, and they can require long-term treatment. Bleeding patterns vary. Why? Because of all of that estrogen. So you have excess estrogen, and then as hormones decrease, periods become further and further apart. So that's the norm. They become further and further apart. They're lucky if it's just the switch. So, what's the functional medicine treatment approach? How do we look at the pillars of health when it comes? So what are the non-HRT treatments? The HPA axis, you want to test it. You want that cortisol awakening response with the full cortisol profile. You want to know where your patients are, and you want to be able to show them where they are. Because you can have the same stressor, and it can affect people differently. I love this story. You know, I'm newly in practice, and I don't like to admit, but I've been in practice for 30 years. And early on in my career, I walk in to do an annual exam, and woman's crying. I'm like, what's the matter? I'm getting a divorce. Now, I walk in. I see a patient I've known for a long time. I'm like, oh my God, you look great. What's happening? I'm getting a divorce. It's just different. So the same stressor is different for different people in different times. And so that's why it's nice to have that adrenal test to be able to show patients about how their stress is affecting them. And people say, I'm not stressed, and I go, okay, because, you know, life is perfect, marriage is great, no financial issues, no issues with their friends, no issues with their kids. So a buzzword or a code word for stress is, do you consider yourself overscheduled? They're like, oh my God, are you kidding? And so, you know, that word overscheduled takes away the negative associations of saying I'm stressed, because sometimes saying I'm stressed, some people say is admitting failure, et cetera, et cetera. So I use the cortisol test so I can show people how their schedules, how their scheduling is affecting their body. And, you know, there's so much inflammation, right? So hot flashes are worse with inflammation, periods are worse with inflammation, PCOS is worse with inflammation. Inflammation is the garden in which breast cancer develops. So we've got to make sure our patients aren't inflamed. Checking their thyroid, their iodine levels. I do a fasting urine iodine level on every patient. It's important for the thyroid also, for the breast. Obesity, insulin resistance. I want to optimize estrogen metabolism, that 2,4,16. What carbon are they hydroxylating? Is it a healthy one or an unhealthy one? And then we'll go through everything that we do. Acupuncture is helpful. And of course, a ton of botanicals, right? You've got 2 companies out there. I use both of them. So whether it be Estrovera, whether it be black cohosh, whether it be Femerin, these are products that are very helpful. So the botanicals support the adrenals. You now see how everything is related. So not only does an altered HPA axis make symptoms worse, an altered HPA axis causes imbalances in the gut and in hormone health. So phytoestrogens and soy, phytoestrogens, black cohosh, red clover, all of these phytoestrogens and soy. As I said, soy is a food I have no issues with as long as it's non-GMO. I think fermented soy is better than non-fermented soy. However, soy isoflavone is a supplement. You can take too much. So you just have to be very careful keeping your dose, under 75 to 100 milligrams a day of soy isoflavone. Natural hormones. Well, Vitex or chasteberry, literature looks pretty good that it helps increase progesterone production. That's going to help a lot of these estrogen excess symptoms. And support for menopausal symptoms other than hot flashes. Get your patients to sleep. When they sleep, they will flash less during the day. Mood is so important, and hot flashes create disturbed mood create more hot flashes. So this is where the doctoring comes in, right? This is where you and your patient figure out where you're going to start. Because when you think back to Dr. Gersh's slide of all the things that go wrong with people, that's the same for everything. So you have to figure out where to start with your particular patient. Stress, toxins, disordered gut. There's just so many places to start. So here's that hormone roller coaster, the lowered progesterone. And eventually your patient may need estrogen, but not yet. We don't give estrogen here. One of my big bugaboos is when people come in from other doctors who were given estrogen in perimenopause. And unfortunately, the treatment for some perimenopausal patients by doctors that I see are giving birth control pills. Right? So you can see why that wouldn't be such a good thing to do here, right? Now, it can help in certain cases when patients are going through the ultra-low hormone levels, but I think that should be documented because that's not the classic. And I'm not going to say that I'm a big fan of oral contraceptives at all, but I just want you to understand why it's inappropriate here, not because I'm saying allopathic approach to this is wrong, never use OCPs. I'm just saying this is where you do not give any excess estrogen. If you're going to give a hormone, you give progesterone. That's the key message here. Because we're treating the root cause, we're treating the underlying imbalance. Right? Now, this is important because we can't assume that this means that there are underlying imbalances, because as I said, it's the biological or chronological clock where the ovaries become less efficient that cause them to produce these fluctuating levels of estrogen. But it's the underlying health of the patient that explains how these underlying fluctuations will be experienced. So it's very hard to change the underlying fluctuations other than, as I said, with chasteberry making more progesterone, or getting rid of inflammation because lipopolysaccharides lead to less progesterone production. Remember that? So we can do a little bit of that, but the major driver here is chronological. But what we do when we're looking at our pillars of health is make it so the experience of this chronologic process is not as bad as it needs to be, right? We can really improve the experience of these hormonal fluctuations. So progesterone may be helpful. We may want to give it in a transdermal oil, a transdermal gel, a transdermal cream. There are differences in laboratory assessment of progesterone. I'm not going to get into that because it doesn't matter. When you're giving progesterone only for perimenopause, you don't have to measure anything. You just want your patient to feel better, and you really can't overdose them transdermally, because to get to a level of transdermally, they'd essentially have to take a progesterone bath, right? That's how much cream you'd have to use, right? So 20, 40, 60, 8, by the time you're getting to 40 or 50 milligrams or 60 milligrams of transdermal progesterone, that's a lot of product to have to rub in. So you don't really have to worry about that. So progesterone can actually theoretically help reduce breast cancer risk by changing that estrogen-progesterone balance, number one. And number two, by affecting estrogen receptors, because progesterone downregulates estrogen receptors. And it's an estrogen receptor issue that drives garden variety breast cancer. So it calms the uterus, it calms the mind, it helps with sleep, helps with vasomotor symptoms, helps the heart, improves bone density, decreases painful periods, improves anxiety. Progesterone and perimenopause, if we're talking about hormonal go-tos, that's the hormonal go-to. And it's always nice to have a cycle map that documents either excess progesterone, either excess estrogen or low progesterone. We can use oral micronized progesterone. You see the word progesterone all the time. You'll never see the word progestin. Progestin is a synthetic progesterone. There's no reason to ever use it. Just don't ever use it. Use oral micronized progesterone. It can be compounded. It can be pharmaceutical. I will leave it to the people that are exhibiting with compounding pharmacies to tell you why it's better than a pharmaceutical. There are reasons, but it's always got to be micronized progesterone. Transdermal works as well, when people need less. You can overshoot with oral. How do you know you're overshooting? Either patients become agitated when they take it to go to sleep, or they can't wake up in the morning. Sometimes dreams are too deep. Okay, so now let's talk about menopause. So here we are, our fluctuating levels have stopped fluctuating, and we're now low levels of estrogen and progesterone. So you need to have more than 12 months of no periods before you get an official diagnosis of menopause. I will tell you, patients don't need to wait that long to know that they're in menopause. So the vasomotor symptoms are increasing, your FSH and LH are elevated, because remember, these are the drivers to produce an egg and produce estrogen. You're not producing an egg or making estrogen. Low estrogen levels are diagnostic, and low anti-Müllerian hormone. You heard Dr. Gersh give an eloquent explanation of anti-Müllerian hormone. It's about recruitment, as she said. So we no longer are trying to recruit here. We've sort of given up. But another way to look at what AMH is the activity going on in the ovary. And so there's not a lot of activity going on here. So family history matters. So the age that a patient's mother and grandmother hit menopause matters. So the primary indication for treatment can be symptoms, and I showed you why that's important, because hot flashes lead to cardiovascular damage. So we want to address them not only to make our patients feel better, but to make them stay healthy and know they can continue for many, many years. And what we see here is changing hormone levels, which you really don't need to measure. It doesn't matter. There's no period. There's estrogen deficiency symptoms. Welcome to menopause. Do an estrogen level, an estradiol level. Now, you need to do a Dutch test if you can't figure out what's going on symptomatically. You need to do a Dutch test if your patient wants to know about their risk for breast cancer and how to reduce it. You need to do a Dutch test if they're overscheduled, right? So during menopause, we have estrogen from peripheral tissue, primarily visceral adipose tissue, that starts to happen. And you end up with fewer follicles and less estrogen that comes from the ovary. So since women spend 1/3 of their lives in menopause, it's important to determine if low estrogen levels impact chronic disease development, heart, bone, etc. So before, we said you can give hormones or you can do something to get rid of symptoms. And remember, you have to get rid of those flashes, because flashes aren't good for their physiology, for their health. The old way of being stoic and going through it without anything isn't good. It's not in the best interest of your patients. Now we're going to talk about something else, which is it in the best interest of your patients not to just not have hot flashes? So let's say you gave them blood cohosh and they don't have any hot flashes anymore. Can you stop there? Or do you actually have to consider giving hormones? Is it in the best interest of your menopausal patient to get hormones? And that's a question that can be answered. And the areas that we have studied, when I say we, I mean conventional medicine, the medical world, is heart, brain, and bone. So we've looked at cognitive function and the preservation of cognitive function. We've looked at heart disease and preventing heart disease risk, because when women hit menopause, all of a sudden that cardioprotection goes away and they start to have heart attacks at the same rate as men. So heart protection and osteoporosis, so heart, brain, and bone. So the menopause and those future health risks. So low estrogen, those ovaries aren't efficient anymore. High estrogen, low progesterone, that's perimenopause. It's also if we're giving improper hormones. So low estrogen, heart, brain, and bone. It's also not good for the vagina. High estrogen, low progesterone is not good for breast cancer or uterine cancer. So the challenge of figuring out this whole hormonal question is, can we do good with heart, brain, and bone and sexual function? So can we do good without doing bad? Right? How do we minimize these risks on the right and not increase these risks on the left? So when we look at heart disease, what we see is it's now the #1 killer of women, especially once they hit menopause. 50% of deaths are cardiac related, way out of proportion to breast cancer. And if they're not given estrogen, it stays really high. The lifetime risk of developing heart disease, 32% in women, but it lags in men by 10 years. And then after a first cardiac event, it then becomes comparable to men. Endogenous estradiol is cardioprotective, meaning that's why women don't really get heart attacks before menopause. Low menopausal levels increase that heart disease risk, and giving estrogen in women or to women that are less than 60 and within 10 years of menopause decrease not only heart events, but all-cause mortality. Now that is a jaw-dropping little bullet, if you ask me. And by bullet, I mean that little thing there. Right? That is jaw-dropping. My patients don't know that. A lot of doctors don't know that. When we're talking about women that have had their ovaries out surgically, it's a must. And progesterone doesn't increase or decrease heart disease risk. So whether you give progesterone, it's not going to hurt their heart. So we have this thing called the timing hypothesis that says initiating ERT early may reduce heart disease risk. What about bone? So this is really the message. HRT helps when it comes to heart. Bone, this is easy to go through because it's pretty clear. Estrogen helps bones. So does progesterone, by the way. Right? Micronized progesterone also. So there's a lot of osteoporosis and osteopenia out there, and there is a lot of controversy about how bone density is measured. And there are some people saying that it's really all a scam, and that we're overdiagnosing osteopenia and osteoporosis so that we can overtreat it. And I think that, you know, as for me, I'm not an expert on the sort of broader epidemiological perspectives on whether it's a scam or not. All I can tell you is that if osteoporosis or osteopenia is overdiagnosed, and my intervention is a medication that can cause someone's jaw to dissolve, I really will think twice about worrying about osteoporosis, right? But if what I'm doing is reducing stress and telling patients to exercise and eat a diet that's alkaline as opposed to acidic, and to stay away from dairy, then I think it's okay. I'm not really worried about how overdiagnosed it is, because I'm doing things that make them healthier, and that diagnosis of osteopenia is a motivator for eating that alkaline diet, right? Now, severe osteoporosis, I have patients that break their hip and get pulmonary embolisms and are really, really sick, and sometimes they die. So I don't want to minimize the seriousness of severe osteoporosis, but nor do I want to overestimate the seriousness of osteopenia, right? So that's how I think this through with my patients. So osteoporosis, the fracture risk is so relatively high, it's combined with breast cancer, uterine, and ovarian cancer. You add them up, and that's osteoporosis risk. Now, this is important because when you take care of patients that are younger, you need to stress the importance of healthy diet, healthy activity levels, and exercise, because peak bone mineral density occurs early adulthood. So that's when you have to make deposits in that bone bank, right? With keeping kids active, making sure they're getting lots of green leafy vegetables, which is the best nutritional source of calcium. That also helps keep them alkalinized. So here you see peak bone mass, how it happens between 10 and 25 years of age. And that's the bank, the bank where the withdrawals of bone mass start to happen around perimenopause and menopause. Whatever their bone density is, when they were in adolescence and young womanhood, that's where they're going to start withdrawing at menopause. So, estradiol should be considered the first-line therapy when we're not concerned about breast cancer risk. So estradiol prevents osteoporosis, increases bone mineral density. It's not debatable. It's not debatable. Now, I'm not saying every woman or every patient that isn't concerned about breast cancer should get estrogen. You're the doctor, you're talking to your patient. What I'm saying is that through the lens of osteoporosis, or through the lens of bone health, estrogen works best. That's what I'm saying. And then when you stop it, bones start to thin again. Progesterone helps either with estrogen or by itself. There's a role for progesterone alone for bone health. And what I always do with my patients is I do a Puralinx test. Is everybody familiar with that Puralinx test? So that's a way of measuring. It's done by Standard Quest Labs or any lab. You can measure the bone metabolism, bone loss, and I give my progesterone, usually micronized progesterone, 100 milligrams QHS, and then 3 months later I like to see that bone loss or bone turnover has decreased. That way I don't have to wait 2 years for the next bone density. So don't forget the pillars in osteoporosis. Estrogen and progesterone we talked about. Vitamin D, can't forget about vitamin D. Vitamin K, Vitamin K2 in the form of MK7, and now you know, I hope, that when you're giving vitamin D in anybody over 40, you want to give it with vitamin K2, right? Because that decreases calcium deposition in the arteries. So we're giving vitamin D with K2 and some calcium. We're optimizing gut health. We're managing stress. Dairy increases the risk. Why? That's a good question. So the United States has the highest calcium intake of any country in the world. We happen to get it through dairy, but we have the highest intake of any country in the world. We also have the highest incidence of osteopenia and osteoporosis. And it's because of the dairy. Dairy is acidifying. And so what we do is we then leach calcium from our bones in order to create more alkaline with bicarbonate. So dairy, this is just yet another reason why we shouldn't be eating dairy. Weight-bearing exercise, an anti-inflammatory diet, we all know what that is. Alcohol, smoking, optimize body weight. So osteoporosis, HRT helps a lot. So let's talk about cognition. I will tell you that my patients are more afraid of Alzheimer's and cognitive decline than they are of breast cancer. Would you all agree? So this is really an important topic. And I spend a lot of time talking to patients about this and really sussing it out because it's important. Because the studies are inconsistent. So all we can say is, this is the best information we have now. And I say, I will make a commitment to you that I'm going to stay on top of this, and if things change, we'll change, right? But right now, I'm giving you the leading edge treatment based on the most current of the literature that's out there. So some of the basics: surgical menopause associated with cognitive decline. Unclear whether low estrogen is a key contributor to age-related cognitive decline. So does HRT help? So there's a lot of studies that say it works. So what I like to do when I'm explaining this to patients is I say, I want to talk to you about why I think estrogen might be helpful. Because I know that estrogen does a lot of great things in the brain. Your brain wants, loves, needs estrogen. Dr. Gersh talked about this. She was right on. It's anti-inflammatory in the brain. It can be pro-inflammatory in other areas of the body, but in the brain, it's anti-inflammatory. It helps with regeneration of brain cells, of neurons. It helps with neurotransmitters. It's great for the brain when we look at the sort of physiology, or what we would call biological plausibility studies. So if you just look at biological plausibility, you'd give everybody estrogen to protect their brain. But when we look at the studies of women that are given estrogen, it doesn't speak to us that it's so helpful. Now, I could tell you why that is, and I believe Dr. Gersh touched on why that is, because of the type of estrogen that was studied. And then if we decide to look a little further, when you use the type of estrogen that we should be using, which is estradiol and transdermal estradiol, then that's the sweet spot, right? So potential cognitive benefit of both estradiol and progesterone, but it needs further study. So what I'll tell you is estradiol, transdermal, and progesterone, with or without a uterus. There's good data, or at least one great paper, that progesterone micronized, not the synthetic progesterone also does great things for the brain. So if I'm talking about giving estrogen and my perspective is my patient doesn't have a uterus, do I need to protect the endometrium? You don't need to protect the endometrium because there's no endometrium to protect, so you don't have to give estrogen, you don't have to give progesterone. But if I'm looking through the lens of I'm concerned about my patient's brain, then I feel better if I'm giving progesterone. But you guys need to, all these papers are referenced, decide for yourselves, right? And discuss it with your patients. For me, it's a no-brainer. My patients get both. So it's only as clear as mud if you don't know how to wash the mud away. When you wash the mud away and look at the compounds that are given, estradiol, transdermal, progesterone, micronized, it's a no-brainer, pun intended. Now, in heart disease protection, we talked about giving it early on, close to menopause. The same is true for brain. Give it close to menopause. We call this the critical period hypothesis. The cardiologists call hormones started around menopause to be the timing hypothesis. So you've got the critical period for brain, timing for heart. And if you wait too long, cognition outcomes are negative. I try not to start HRT for cognitive impairment 5 years or more after menopause. I never start it 10 years or more after menopause. So between years 1 and 5, I'm okay with it. Between 5 and 10, not so sure. Never after 10. So it is all about timing. So, and here we see, again, perimenopause, this hormonal roller coaster of the estrogen, and then here we see starting with progesterone early on, then progesterone with estrogen, and then how long do we continue? Rarely 10 years or more. I think the references in the literature where they talk about an age, like 60, is irrelevant. All that matters is the number of years out of menopause. So find out when your patient's last period was, that's when you start, and then you can use the 5 or 10 year window from that. Ignore chronological age. So, heart disease, hormones help. Bone, hormone helps. Cognition, as I said, the benefits are unclear when you look in the broader literature. When you look in the narrowed literature, it's very clear. Vaginal atrophy, very clear. Hot flashes, etc., very clear. So, what's the dilemma? Heart prevention. Treatment benefits up to 10 years and maybe even longer. Osteoporosis, the longer you treat, the better. Cognition, it's unclear, as I said, only when they study the wrong things. So, how do we do this in a safe way? We do it so that we can minimize these risks and don't increase breast cancer or endometrial cancer. So the major risk associated with HRT is breast cancer. This is important because anytime I talk to patients about hormones, if they don't ask me, they want to ask me, is this going to give me breast cancer? So, should breast cancer risk be assessed in every woman considering HRT? Yes or no? Absolutely. In fact, we now have recommendations that we have to assess it in every patient we see. but we certainly have to do it. So this is critically important. So this is the big no-no, right? We all know what the classic contraindications are for giving estrogen. Now, what are the risk factors for breast cancer? So when I think about this, I think about green light, yellow light, red light. So we just went through the red light. Green light is there's no reason not to give estrogen. Yellow light is everybody in between. And so these are the risk factors. Increased BMI and obesity, high insulin levels, diabetes, high estrogen exposure, high baseline estrogen. So did you know that if you have a patient that's in menopause and you do a serum estradiol and it's elevated, that she's at increased risk for breast cancer? Absolutely. We need to be doing those levels on our patients. Dense breasts, as we talked about. Parity, having no children. Abnormal estrogen detoxification and methylation. That's the key area that makes you a specialist, because you understand pillars of health, functional medicine, estrogen metabolism, and exposure to toxins. Dr. Gertz talked about that a lot. And then there's genomic risk factors from strong family history. What if they have a estrogen metabolism SNP? We talked about cytochrome P450, right? 1A1, 1B1, 3A45. What if they've got BRCA? How many people think if you have BRCA, you can't get estrogen? Just by show of hands. Maybe's good, because that's the answer. But the answer is not a uniform no. The answer is not a uniform no. And I will tell you that early on in my career, I had a patient in her 20s who had her ovaries out for a BRCA mutation. Well, actually, yeah, and I wanted to give her a little bit of estrogen afterwards. And by the way, she also had a mastectomy. And I wasn't allowed to do that. And she's still my patient and has really suffered from not having estrogen for all these years. So we just have to think about, in a more global way, what's in the best interest of our patients. So how do we minimize the risk factors for HRT? So as I said, the timing hypothesis, 10 years, the benefits outweigh the risks. Older women, not so much. You have to individualize. Women that have had early menopause or have had their ovaries out, absolutely candidates, because I didn't know that women that had their ovaries out have increased all-cause mortality. Actually, I think Dr. Hayes put that on a slide way back in the day, and that just rocked me. 8-year difference. So combined HRT duration, less than 5 years, certainly less than 10. So how to do it? What do we do? You're going to be having a lecture on the details of HRT later, but we're talking about optimizing the pillars of health and I don't know, is this your patient? This is my patient. Inflamed overweight woman with poor phase 1 and 2 metabolism and an HPA axis that's dysfunctional is a very different candidate than a healthy one. We have to individualize. We have to know who's sitting in front of us. And the woman who's sitting in front of us has to know who she is. It's both. Pillars of health. So do optimize the pillars of health. Determine if HRT is appropriate. Mammogram, ideally not dense. Test, don't guess. Check those metabolites, the 2, the 4, the 16. Check the genetics. Choose the hormones. Again, different talk. Start low, go slow, maintain lowest possible dose if we're giving it for symptom relief and safety. If we're giving it for heart, brain, or bone, start low and go slow is wrong. Then it's about giving a standard dose because that's where the data has shown that it's helpful. So that's why you have to individualize. That's why you have to know who the patient is in front of you. And that's why she has to know why she's taking estrogen. Because if it's because the black cohosh and the estravera and the femorin didn't control her flashes, so you're giving her estrogen, start low and go slow. But don't think you're going to be helping heart, brain, and bone. Select the carrier and route of administration, decide the doses. Again, you're going to get all of that. And then we have to monitor outcome. So, oral bioidentical estradiol is effective. Transdermal estradiol is preferred. This is not questioned anymore. And then, 6 to 12 months ago, a new FDA-approved combo of oral estradiol with micronized progesterone just came out. But it's oral, right? So what I'm saying is, it's so clear that transdermal is better, and now they just produce an oral. So transdermal is as effective as oral when it comes to heart, brain, bone, and when it comes to symptoms. And patients don't have issues with lipids, and patients don't have issues with stroke, and patients don't have issues with clots. Transdermal is safer than oral. It's well known. It's not contested. So transdermal is safer and as effective. So transdermal, no increased risks of anything, but lots of benefits. It's a no-brainer. Bioidentical, meaning estradiol, preferred compared to Premarin or a synthetic progestin. So never a synthetic estrogen, never a synthetic progesterone. Bioidentical, you're going to hear more about that. It's the best choice because it's identical to what's in the body. Estradiol, progesterone, and testosterone. There are no FDA-approved estriol options. I'm not here to talk about estriol. That's coming later. HRT success can be achieved with products that are not FDA-approved or that are FDA-approved. This is for you and your patient to decide. So use compounded hormones if there's a peanut allergy, because you can't use prometrium, if they may be sensitive to a carrier, if they prefer to use vaginal estriol, if you want to tweak ratios. And document. Know your compounding pharmacist. Not all compounders are the same. This is just reinforcing. Saliva testing shouldn't be used to monitor transdermal hormones, ever. So this is how I give it. Oral progesterone, 200 milligrams to match a patch of 0.05. Start low, go slow, and maintain lowest possible dose for symptom relief. And if we're talking about heart, brain, and bone, this is the dose. Progesterone inhibits estrogen-stimulated breast epithelial cells. Progesterone is breast protective. It downregulates ER alpha. Remember, ER alpha is stimulatory. Inhibits antihypertensive activity of estrogen, so you don't give tons, but then again, sometimes it can also help. So this is one of those things that aren't all that important, but it definitely helps with falling asleep, helps with disordered sleep. 200 milligrams offers the best endometrial protection. And I prefer continuous rather than cyclic. There are people that prefer cyclic. The literature, I believe, shows that the endometrial protection is better with continuous. I also like continuous because of the effect on the brain and because of the effect on the breast. There is some thought that continuous leads to insulin resistance. And sometimes patients really don't like progesterone. And so now there are doctors that have patients on cyclic progesterone once every 3 months with continuous estrogen. So there's a lot of different ways that people can dose right now. I personally think continuous is the best. So I do a patch combined with oral progesterone, and that's how I address these very low hormone levels and help patients to protect heart, brain, and bone. Transdermal progesterone, as I said, if I'm giving estrogen, I never do transdermal progesterone if the patient still has their uterus. It doesn't give endometrial protection. That's very clear. So transdermal estrogen, oral micronized, continuous, I think, is best for the endometrium, and I also like it because of the protection of the brain. Vaginal progesterone may be effective, but again, not in women that have a uterus. Never use transdermal progesterone in women on ERT with a uterus. So let's look at vaginal progesterone, vaginal DHEA, estriol cream, etc. There's a lot of other stuff out there. Vaginal progesterone can give endometrial protection when used with a low-dose patch for 3 to 5 years, but it's off-label. So we didn't talk about vaginal atrophy and incontinence. That's now called the genitourinary symptom or syndrome of menopause, GSM. GSM is bothersome. Of course it would be. It's highly prevalent. Almost everybody has it. The statistics say 84%. I'd say 98%. And you know what this is. Bothersome, genital irritation, dryness, burning, urinary urgency, dysuria, recurrent UTIs, pain, dryness, and that leads to decreased intercourse frequency and the libido. And we obviously, anyone that's done any kind of GYN exam knows the classic signs, and you don't need a lab to diagnose this. In fact, you rarely need a physical exam to diagnose this, though of course you do. But I've never thought that someone had vaginal atrophy, and then I didn't find it. So people start with lubricants, water-based, vaginal can change the vaginal microbiome. That's why we say water-based in general. There are lots of people that want oil-based or that use olive oil or coconut oil. As long as it doesn't cause a problem for them, fine. They will erode condoms. So if that's an issue for, not so much for pregnancy, but for protection against STDs, women need to know that if they're going to choose an oil-based lubricant. But if they're in a monogamous relationship and comfortable with it, I see no problem with it as long as it doesn't cause an issue with infection. So, sexual activity is an intervention. It can help. Pelvic floor physical therapy, vaginal dilators, vaginal estrogen. You can use estradiol, you can use estriol, you can use DHEA. Lubricant if you can't or don't want to use estrogen. Make sure, if you're going to use vaginal estradiol, that levels are in the postmenopausal range if you don't want to avoid systemic effect. Now, I have oncologists that say you can give their menopausal patients vaginal estradiol because they're not concerned about systemic absorption. But make sure you have this conversation with your patients. I am not concerned about about systemic absorption of vaginal estradiol, but there's always going to be one patient in one practice when you say I'm not concerned about it that decides to use it 10 times the way you told her to do it, right? So I'm not concerned about it as long as they use it how I tell them to use it. And you want to make sure there's no uterine pathology, vaginal E2, estrase, a ring, tablets, and the data shows that it has very low systemic absorption. And estriol binds ER beta better. It's compounded. We use this a lot. Better safety profile for breast health, and it works. Vaginal E3, 0.5 milligrams per gram, 1 gram every day for 2 weeks, then 2 to 3 times a week. And it's got to be compounded. So we've got a compounder here that's exhibiting, and you can talk to them about the details. Now, what I will tell you is that because we're a functional medicine practice, we have a lot of patients that come to us with severe vaginal symptoms, right? Whether it be vulvodynia, whether it be lichen sclerosis. And so sensitive vaginas don't always do well with commercial estrogen vaginal products. And it's not because of the estrogen, it's usually because of the filler or the binder or the base. So this is where compounding pharmacists shine, because they will be on the phone with different options for bases. Hyaluronic acid is a great base, and hyaluronic acid alone has no estrogenic effect, but can often lead to symptomatic relief. But when you're working with a compounder and someone that has really bad vulvodynia, you can add other things. You can add a little bit of an anti-inflammatory if you want. You know, you can add different things, and you can talk to them about what success they've had in other practices and decide if you want to try it. So this is where compounding pharmacists shine. So E3 is probably a little bit safer than E2 when we're going vaginally. So DHEA. DHEA is FDA approved. It's called Intrarosa. 6.5 milligrams every night. Helps with atrophy. Doesn't lead to systemic hormone levels, so you're not going to increase estrogen levels. Doesn't cause endometrial thickening. The benefits outweigh the risks. It's postmenopausal, and the efficacy and the risk factor profile in women also using estrogen patch is unknown. What that means is, can you give it in addition to someone that's using an estrogen patch? I don't know. I don't mind doing it. It doesn't affect levels. Don't give more than the 6.5. Not a lot of long-term studies. Testosterone cream. So testosterone is the most abundant female hormone, and the maximum concentrations during the third and fourth decades, then they decline. There are androgen receptors everywhere, including the breast. Now, we're not going into testosterone replacement therapy in women in a big way, but they have an effect on the androgen receptor. It's the precursor hormone for estradiol and has an indirect effect on the estrogen receptor via aromatization. So, women feel better when their testosterone level is normal. What does testosterone do to SHBG? It decreases it. So it leads to more free testosterone and more free estrogen. So there's a theoretical risk of testosterone increasing breast cancer risk because of the binding on the androgen receptor in the breast, as well as creating more free estrogen. So testosterone replacement therapy may improve sexual function. DHEA is a much safer way if we're talking about libido before testosterone, and you can improve sexual function by giving estrogen. You can improve sexual function by improving the 4 pillars, working on relationships, etc. So the data on testosterone is inconsistent. There are some studies that show an increased risk of breast cancer and some studies that say there aren't. So it's not FDA approved for women, but it's compounded. We give it as a cream, we give it as a gel, and some people are using pellets. No long-term studies. I'm not worried about transdermal for the endometrium, but oral testosterone sometimes, and I don't know what to do with pellets. So there's no randomized study about breast cancer with testosterone as a primary outcome. There are studies with it as a secondary outcome, and sometimes it's worse, sometimes it's not. And pellet therapy shows no increased risk in breast cancer. As far as preliminary studies, there's really only one author who does it, who happens to be linked to the pellet industry. So when you add testosterone to estrogen and progesterone, that's a no-no. That's when you end up with cancer. So you don't want to do that. So here we say there's no evidence that the addition of transdermal testosterone to transdermal estrogen and oral progesterone increases breast cancer risk. That's a true statement. But when we were giving an oral testosterone, then we were getting more breast cancer.